Okay, so good evening, everybody, and welcome. My name is Andrew Cairns, and I'm the Health Services Manager at Arthritis New South Wales. And welcome to our last webinar for 2023. Tonight, I'm thrilled to be able to introduce our guest speaker, and we are very privileged to have Professor David Hunter with us. Professor Hunter is a rheumatologist, clinician researcher, whose primary research focus is clinical and translational research in osteoarthritis. He is ranked as the leading expert in the world in osteoarthritis on expertscape.com and has over 600 publications in peer-reviewed journals on this subject matter. He is the co-director of Sydney Musculoskeletal Health and leads the osteoarthritis team at the Cooling Institute, which is dedicated to improving our understanding of osteoarthritis and the quality of life for those who suffer from this prevalent and sometimes disabling disease. Tonight's topic is osteoarthritis and myth busting. And we know that there are many common myths associated with osteoarthritis and that they can significantly influence people's beliefs and behaviors when it comes to managing their condition. So really, who better to bust a few of these myths for us than Professor Hunter? I'll now hand you over to him to start our session. Thank you, Professor Hunter.
Thanks very much, Andrew, and thank you to Arthritis New South Wales for the opportunity to be with you this evening. And thank you all so much for coming along, and really looking forward to the interaction that hopefully we'll be able to have towards the latter end of this hour. As Andrew's intimated in the beginning, there are lots and lots of misconceptions and myths that abound in our community about osteoarthritis, and I'm going to try to touch upon many of them tonight, but very happy to take questions about any others that you might have as well. In the first instance, though, I would like to acknowledge the traditional custodians of the land on which I work and live, and that's the Camaragal people and whatever lands that you're sitting upon, and recognize their continuing connection to land, water, and community. I'd also like to pay my respect to elders past, present, and emerging. Most of the support I get for the work that I do comes from the federal government through the National Health and Medical Research Council, and also through the endowed chair that I have at the University of Sydney and Royal North Shore Hospital from Arthritis Australia. I work as the editor-in-chief of Osteoarthritis and Cartilage, section editor for Up to Date for osteoarthritis, and I also received some funding from the National Institute of Health in the US. Most of the remainder of these declarations have nothing to do with the content I'm talking about tonight. For those of you that like to indulge in reading a little bit of scientific literature, please, by all means, avail yourself of these references. If you're having problems sleeping, this may also be another panacea for you to assist in promoting a little bit of sleep. But oftentimes what I try to do with a lot of the content I bring out as publications in the scientific literature is also try to recreate that content on joint action so that it's done in a way that hopefully is a little bit more friendly to a lay consumer-based audience. So that's a podcast we've started a few years ago now. As I go through this presentation, I guess I'd just encourage you to reflect a little bit on your experience of not only living with osteoarthritis, but the experience you've had in dealing with health professionals in the community, and potentially some of the pervasive misconceptions and myths that get spread around. So try to make it relevant, because I think you'll gain a lot more from it if you do reflect on your own experience. Now, I'm going to just tell a little bit of, I guess, a story from a case study. And potentially this is germane to you, but maybe not. But in any case, Barbara is a 65-year-old grandmother with 6 grandchildren who has osteoarthritis of her knee and a body mass index that puts her in the overweight category. She used to enjoy tennis with her grandkids and bushwalking with her husband, but unfortunately she had to stop a lot of those activities and retire at the age of 60 because of pain in her knee. And the last time she was pain-free was 3 years ago. She visited a general practitioner who recommended an anti-inflammatory, but unfortunately that gave her indigestion and exacerbated her high blood pressure. And then she'd had a steroid injection, which gave her about 2 weeks of reduced pain. And last week, she was referred to an orthopedic surgeon who recommended she have a knee arthroscopy. And I'm not presenting this case because it's the ideal way the disease should be managed. I'm presenting it because it's going to help to illustrate some important problems we see on a regular basis with the care and management and understanding of osteoarthritis as a disease. Now, you may well have seen some of these misconceptions in the way your disease has been communicated and the way it's been handled by different healthcare professionals. But essentially, all of the things that are there on the left-hand side are misconceptions. The things on the right are facts. So joint pain is not necessarily a sign of damage. It typically doesn't get worse with time. Weight bearing is advantageous as long as you can tolerate that. Exercise-based interventions can't help damaged joints, and surgery is the only cure. And so all of those are misconceptions, and I'll touch upon most of those tonight and hopefully put them in a light that helps to illustrate the way we should be conceiving and managing this very prevalent disease. I'm going to start off with, I guess, our understanding of what osteoarthritis is. And historically, it's always been, I guess, abound in the community that this is a disease that predominantly affects cartilage. And again, that's a myth that I think it's important we understand that this is a disease of the whole joint. And for Finding Nemo fans, they'll know this as Bruce, but essentially the relevance of Bruce to this is that you don't get osteoarthritis unless you've got bone. And as you know, sharks have a cartilaginous skeleton, and at least from an evolutionary perspective, there were no animals that had osteoarthritis until bone became pervasive. So you need bone, you need cartilage, but you can't develop it just with cartilage alone. And for those of you who are thinking, okay, well, it's because Bruce is in the water. So whales have a skeleton that also includes bones. They also get osteoarthritis. So it's not just because Bruce is in the water. All right. So a lot of people, when they think about osteoarthritis, talk about the disease, which is the pathologic change. And I'll touch upon that in a second. And they think that those structural changes equals the symptom experience. Again, that's an important myth we need to bust. So two concepts. So one is about the disease. The disease is the change in the structure, the change in the pathology of the joint, which affects potentially all of the tissues within what we call synovial joints, such as this, which is a knee. So it can affect the bone, the lining of the joint, what we call the capsule, the inside lining of that, which is the synovium, the ligaments, the muscles, and obviously it can also affect the cartilage, but it's by all means not just a cartilage-based disease. And so this is a disease of the whole joint. Now, that is the pathologic change. That's the disease. And it's important that you understand that from your perspective, the disease doesn't much matter. It's really what you are experiencing or the illness that does matter. And so a lot of the time when, you have an X-ray or you might have an MRI, and I'm not advocating you need either for diagnosing this disease, but you look at the X-ray, you look at the MRI and you say, well, it doesn't really explain why I've got pain, or it's surprising why I have so little pain as a consequence of that X-ray or MRI. Because oftentimes there's a marked discordance between what we see structurally on imaging and what a person experiences. And so the next slide, and I apologize for its complexity, but it relays a couple of important points, and I'll try and break this down. But typically when we think about why a person experiences pain in the context of osteoarthritis, we talk about what's called a bio, so the biology, psychology, social model. So the etiology, the origins of pain in osteoarthritis are complex. The biology usually relates to local structural changes that can occur within the person's joint that has osteoarthritis. They're then processed peripherally as pain signals, but most importantly, centrally, and particularly concomitant presence of depression, stress, anxiety, and people oftentimes who come from lower socioeconomic circumstances, that markedly modifies the pain that they experience. So this has a small role to play. This has a much larger role to play. And so when a person expresses pain behavior, distress, and disability, oftentimes in large part, it relates to this. In small part, it relates to this. So when we ignore this, we do so at our peril. And, historically, there wasn't much heed paid to the importance of mental health. Fortunately, that's changing, but it plays a really important role in the context of the symptoms that a person experiences. Again, a myth that's important to bust, that diagnoses of a person that has osteoarthritis are made based on an X-ray. And so irrespective of what part of the world you live in, whether you live in the UK, and this is the Clinical Excellence Commission, whether you live in Europe, and this is the Rheumatology League in Europe, this is the American College of Rheumatology League in the States, this is how a diagnosis of osteoarthritis is made. So it's based on what we call a clinical diagnosis. So it's based on the symptoms a person presents with. So that's joint pain, little, if any, early morning stiffness and functional limitation, and a few salient features on clinical examination. But you'll note here that to make the diagnosis, we don't need an X-ray. We don't need an MRI. So that's the importance of that clinical diagnosis. And you're probably saying, well, why not get an X-ray? Why not get an MRI? Well, potentially it can cause more harm than good. It's very hard for you to unsee the damage or trauma in your knee if you've looked at the MRI report. And as a consequence of people who do get an MRI, who get, for example, a report that says, you have a meniscal tear, which is universally occurring in the context of osteoarthritis, you're about 10 times more likely to get an arthroscopy. And I'll come back to this later, but we know that that's not going to lead to benefit. So higher rates of investigation using imaging is likely to lead to higher rates of intervention, and unfortunately, not necessarily better outcomes. So when we see a person who presents with osteoarthritis, ideally, what we should be doing is paying attention to those psychosocial factors I mentioned a moment ago, to assess pain, to assess function, to look at your attitudes towards physical activity and exercise, because these are obviously core components of the treatment that we'd like to instill, to look at your presence of support, the influence of comorbidities, which I'll come back to again. The vast majority of people who have osteoarthritis have 2 to 3 comorbidities, and it's important when we manage someone who has osteoarthritis, we don't make them worse. And then identify these modifiable risk factors, because these are things that we can target with our management. And so that's what we mean by a holistic assessment. In contrast to historically, what's happened is people get an MRI, they identify structural changes that are on there that might reinforce their desire to go and get something passively done, such as surgery, which more often than not, particularly in the context of arthroscopy, is not going to favorably influence their outcomes. Okay, now I probably have used inappropriate language during the course of tonight's presentation, and I know historically I've done so in my clinical practice, so I'm not immune from using terms that are inaccurate and inappropriate. And I'm sure you've seen a lot of these terms, bone on bone, wear and tear, degenerative, being used in clinical practice. It's really important for you to understand that those terms are either inaccurate, inappropriate, or generally don't help. So let me explain what I mean by that. So this is what's called a qualitative study, which was done by colleagues at St. Vincent's Hospital in Melbourne, where they took a cohort of people who were awaiting a knee replacement to understand their experience of communication as they had experienced throughout the course of their disease. And they had frequently heard the terms wear and tear and bone on bone. The consequence of hearing those terms, at least from their perspective, they felt that their joint was vulnerable and that the only thing that they could do was avoid activity, and surgery was the only option that was available to them, in large part as a consequence of the use of these terms. And this is, the activity avoidance is felt because they felt that their joint was vulnerable, and in addition, that excess loading might cause additional damage, and that surgery was the only way that that could be fixed. So a lot of those concepts are really wrong, and oftentimes the language that we use can have those consequences. So as at least clinicians, what we're trying to do is move away from what we're calling this impairment discourse, where, basically you're getting older, you're going to need to live with these changes that are occurring in the context of your disease, and there's nothing you can do about it, which, at least for you as a person that has osteoarthritis, is obviously not an empowering message. It doesn't instill in you confidence in your joint. Ideally, what we're trying to do is move towards what we call a more participatory discourse, where you own your knee, that you can maintain the knee, and you can prevent it from getting worse by a number of different things, which we'll talk about a little bit later. So hopefully that's a little bit more empowering, giving you the sense and strength that you can actually do quite a lot with your knee and joint, where you don't necessarily have to just give in to this passive consequence of aging. For those of you that would like to hear a little bit more about those concepts, we spoke to Samantha Bunsley from Griffith University about some of the words that are used to describe osteoarthritis and how they can be harmful on the Joint Action podcast. So another important misconception is that everybody's disease follows a course of steady progression, ending in joint replacement. And again, that's an important misconception I'm just going to try to put to bed now. So there have been a number of these trajectory-based studies looking at the course of pain in people that have osteoarthritis over time. And so this is from a UK study looking at follow-up of pain in people over a number of years. And what you'll see in terms of, this is a numerical rating scale for pain, where 0 is no pain, 10 is the worst pain imaginable. You can see for the vast majority of this cohort, these lines are flat. A small proportion of people get better, a small proportion of people deteriorate. But generally, and this is what, again, we see in most other cohorts, that trajectory of symptoms is quite flat over many years. So this isn't a disease where everybody inexorably gets worse. Oftentimes in the first part of the disease, it's characterized by flares or fluctuations. So this is a theoretical model of symptom progression in the context of osteoarthritis. And when you first develop disease, you might have these brief self-limited episodes of pain that get better in and of themselves. And between times, more often than not, you have no pain. If the disease progresses, then it doesn't necessarily need to progress, but so this is just a stylized figure. Sometimes those episodes become longer, the duration between the episodes shorter, and sometimes you also get this chronic background pain that occurs in the context of that. But people at the end stage of disease, oftentimes they have the chronic background pain, but in addition, still have episodes, but very little, if any, duration of time between them. Now, I know for many of you, you probably think that joint replacement may be the cure and the only way that we're going to fix this disease. For the vast majority of people who have osteoarthritis, they don't necessarily get a joint replacement as part of the life course history of the management of osteoarthritis. And in fact, the overwhelming majority of people, whether you're a man or a woman, whether you have hip osteoarthritis or knee osteoarthritis, never need or require a joint replacement for managing their osteoarthritis. So joint replacement is not inevitable. For the vast majority of people, it's not part of the life course of osteoarthritis. And so you don't necessarily need to look at this and say that that's the only way my disease can be managed. Again, I think for a lot of people, they believe that disease is inevitable if you live long enough, meaning that it can't be prevented. So let me just put both of those to bed. This is a complex diagram, but essentially looks at incidence rates for hip, hand, and knee osteoarthritis, separating women from men for each of these. And what you'll see is that about the age of 70 to 75, the incidence rate starts to drop off. Now, some of this may be somewhat of a bias, but what you'll see for hand and for hip osteoarthritis, that the incidence remains pretty stable and flat after about the age of 70. So osteoarthritis is not inevitable. the incidence tends to flatten after about the age of 70. And it's important for you to recognize, and this is particularly the case for knee osteoarthritis, that the two leading risk factors for disease are both eminently modifiable. So if we look at what we call the population attributable risk, so the proportion of the disease that we can attribute to certain risk factors, the leading risk factor relates to those who are above a healthy weight, and about 20% relates to injury, occupation, and then genes and other stories in here. But these two risk factors are definitely modifiable. And so when we think about predisposing people to the development of disease, we'd like to think that we could do a lot more about preventing it and intervening from a public health perspective. All right. So if we look at the way the disease is managed at the moment, you'd probably like to say that, we're doing pretty well in Australia. Well, I'd like, again, probably to suggest to you that we're not. So this is a little bit of an old study, but a study called CareTrack, which is from 2012. And I don't think things have necessarily improved much since then. And the scale here is the percentage of people receiving appropriate care for a range of different conditions, including osteoarthritis, which is down here. And basically what this figure says is that about 40% of people who have osteoarthritis in Australia are receiving appropriate care. So you might say to yourself, well, what's going wrong? What are we doing wrong? Well, you're presenting with osteoarthritis, and about half the time you're being asked about your pain and function, but about half the time you're not. So if that's your presenting problem and you're not being asked about your pain or your function, that's a big limitation with the way we're currently managing this disease. About 2/3 of the time, you're not being afforded an opportunity for lifestyle and behavioral treatments like exercise, like increasing physical activity, like reducing weight. About 2/3 of the time, we're prescribing the wrong drugs, but we're doing pretty well at referring people to surgeons. But you can see here that there's lots and lots of room for improvement in the way we're managing the disease. Potentially as a consequence of that, the vast majority of people that have osteoarthritis are not satisfied with their treatment. So if we look at many different national health studies, and this is one that's come from the UK, you'll see that satisfaction level really basically reflects that 1 in 3 of you are actually satisfied with the care that you're receiving. Now, I've been involved in the development of guidelines or recommendations for care, both for Australia and for international organizations. And many of these look like they advocate that we treat everybody the same. And again, it's important to, I guess, ideally try and tailor this to the individual that presents to us. Osteoarthritis is an incredibly heterogeneous or variable disease. Everybody who presents with this disease presents unique features, both in terms of the reason why they develop the disease and the way it manifests. And that should be reflected in the way we manage disease. So you may have heard about this concept of phenotypes or different subtypes of osteoarthritis. Some people develop this as a consequence of aging, metabolic phenotype, particularly the concomitant presence of diabetes, obesity, or high blood pressure. Some people have more of an inflammatory phenotype, changes in bone. They may develop osteoarthritis as a consequence of injury, or again, for some people, this may be more cartilage-based. So there's these different subtypes of osteoarthritis that ideally, again, should influence the way we're managing this disease, but at present, unfortunately, hasn't necessarily changed the way we care for it. So this is an infographic that we brought out a few years ago when we developed the College of GPs guidelines. And what we're doing here is we're advocating that the assessment for the disease is holistic, consistent with what I mentioned a moment ago, that the diagnosis is a clinical one and that we don't need routine imaging, and that we tailor a plan of management according to how you present. So we used a traffic light labeling thing to help understand, I guess in green, what we should be doing more of, in yellow, what we should be judicious or cautious about, and in red, things that are happening pretty regularly that we're not advocates for. And so more of this, less of this. And so if we could do that and we could achieve that in the next few years, that would be wonderful. But we've got a long, long way to go. So if we were to tailor a plan of management according to an individual who presents to us in care, the core treatments, the principles around management that everybody should be getting, ideally, is education about the disease and how you can contribute to managing it yourself. The promotion of physical activity and therapeutic strengthening exercise, and ideally maintaining a healthy weight. And so everybody who has osteoarthritis should be doing that. Depending upon how you present, there may be other ways that we can tweak the management so it's more tailored to you. And these are just examples, but there are other ways that we could do that. If you have muscle weakness, obviously we should be focusing more on strengthening. If your predominant problem is that of you being above a healthy weight, we should be targeting weight loss combined with physical activity. If you've got poor mood or sleep, potentially cognitive behavioral therapy. And you might say to yourself, well, there are lots of ways that theoretically we could modify this disease. And these are, again, just some examples, but hopefully some examples that are operational if you're working with the right healthcare professional. Now, for many of you who are taking paracetamol, the next lines that I'm about to say may not necessarily be the most favorite lines that you hear tonight. So paracetamol Panadol was the first-line analgesic in many international guidelines until about 10 years ago. It's no longer the first-line analgesic. And the main reason it's no longer the first-line analgesic is because if we do appropriate placebo-controlled, or essentially a sugar pill-controlled study, and we compare paracetamol to that sugar pill, we don't actually get a clinically meaningful benefit for people that have osteoarthritis. So it doesn't provide a benefit over and above placebo. And I'm not denigrating the fact that placebos can have a benefit. But when we know that the side effect profile is not dissimilar, albeit not as severe as the anti-inflammatory group of medications, then we've got to worry about its safety. So many of you are probably aware that if you're taking regular paracetamol, but then you, in addition, take a cold and flu remedy, which is also paracetamol based, you place yourself at greater risk of toxicity, particularly as it relates to the gastrointestinal tract or liver. So we no longer look at this as the first-line analgesic. About 20% of people who have osteoarthritis are on a long-term opiate. So whether that be oxycodone, endone, codeine, or any variant of that. We know for osteoarthritis that this is not recommended for the management of osteoarthritis, primarily because it has little, if any, benefit over and above a placebo, but a serious risk of harm. And so we know that in the context of people who take regular opiates, they're at greater risk of drowsiness, constipation, falls, fractures, but also addiction potential. And so if we look at gun-related homicides in the US, and this is a pretty old slide now, we're obviously understandably horrified by the number of people who die every year from gun-related homicides in the US. But it's much less than die from prescription drug overdoses from opioids. So it's important that we understand that this causes real societal harm, particularly fentanyl and synthetic opiates, and the risk of harm, addiction, and death is quite high in this context. There are plenty of other alternatives, whether that be, and so this is just to simplify this slide, these are the various international guidelines and the College of GPs guidelines from Australia. And these are various pharmacologic interventions that we might want to consider. So generally what we would advocate for in the first instance is some variant of an anti-inflammatory medication, potentially a gel, potentially a tablet, and again, ideally guided by a health professional, such as your GP or a pharmacist, about your safety profile and your suitability for whether that be topical or oral. Now, again, a common misconception is that injections are an underutilized therapeutic option. And again, I'd like to put that misconception to bed as well. We're just going to touch upon a few of these, but one of the more common ones is these viscosupplements or hyaluronic acid injections. In well-done trials, it provides no clinically meaningful benefit over and above an injection of salt water. So again, that's typically our placebo in the context of these trials, but does carry with it a real risk of harm and a substantial cost. And so as a consequence, most guidelines will not advocate for the use of viscosupplements. Corticosteroids provide, on average, a mean of 2 to 4 weeks benefit over and above a saltwater injection. Osteoarthritis for most people has a disease duration of about 20 to 25 years. Repeat injection may predispose to accelerating the underlying progression of the disease. So again, this is new data, but coming out quite strongly in a number of different studies. And so this is a study we did a few years ago, but basically looking at a cohort of people, comparing a cohort of people with osteoarthritis for some that didn't receive an intra-articular corticosteroid injection, another group that did receive a corticosteroid injection. And these people are 3 to 4 times more likely to have their disease progress over a 3 to 4 year period than those people who didn't receive an injection. So again, if you want your disease to progress, repeat steroid injections is probably a good way to achieve that. This is, again, just to reinforce that concept about viscosupplementation. If we look at the effect of hyaluronic acid on pain change, it has a moderate to large effect. So does intra-articular salt water. And so if we just subtract the intra-articular placebo and look at the effect of hyaluronic acid on its own, this is not what we would call clinically meaningful. So again, it's not something we recommend in clinical practice. Now, I often get asked about the merits and benefits of platelet-rich plasma injections and stem cell injections. And because, there was a lot of interest from the community and a lot of potentially suggestive trials out there, we conducted our own trial. And so this is in collaboration with a good colleague and friend, Kim Bennell at the University of Melbourne, and our team at Sydney. And we ran a trial that was published in an American journal a few years ago, which basically demonstrated that we randomized 288 people, half of them to platelet-rich plasma, half to placebo. They each received 3 injections. And over the course of 12 months, there was no benefit for pain, no benefit for structure from the platelet-rich plasma over and above the salt water. Now, understandably, that's another negative trial, and that upset a lot of people in the regenerative medicine community. But to this point, there are no international guidelines that advocate for the use of PRP, despite widespread community interest and a lot of clinicians out there. Probably the best way to describe it is preying on your interests. Another common procedure that ideally we should be doing less of is arthroscopy. If we look at this particular meta-analysis, and there's a lot of different summations of the different clinical trials, these are all the clinical trials that had happened up until about 2015, and there have been more since that time. Essentially, what this shows is that there's no clinically meaningful benefit for the use of arthroscopy in the management of osteoarthritis compared to physical therapy or sham. And so just so you understand what sham is you wheel the person into the anesthetic bay, you put them to sleep, you make a little nick in the front of their knee to make them believe that they've had an arthroscopy, and then you wake them up. Those people that have the sham arthroscopy do at least as well as those people that have the real arthroscopy. But obviously, they don't get exposed to the harm, and they don't get exposed to the substantial cost. And so if you're thinking that arthroscopy might something you should still consider, understand that the risks that are associated with that include a deep venous thrombosis or clot in the leg, a pulmonary embolus, meaning the clot that goes off to the lung, and risk of death. Similarly, it increases the rate of progression of osteoarthritis and shortens your time to joint replacement. So if you want to do something, again, that's unfavorable, arthroscopy may be a good way to achieve that. Now, total joint replacements are a wonderfully cost-effective procedure for the right person at the right time, but not everybody is suitable for this. So about 1 in 4 people that has a knee replacement has a bad outcome related to their joint replacement. We can often predict how those people are. And so oftentimes, particularly if you're depressed, if you have a body mass index that puts you in what we call the morbid obese category, if you have little, if any, x-ray change, or you have low pain, it puts you in a category where you are much more likely to be a non-responder, meaning your pain is no better at 12 months after the procedure than what it was preoperatively. Now, a lot of people say, well, surely if I replace my knee, that'll be better for all of my other joints. Primarily because for the average person that has osteoarthritis in their lower limbs, they have 2.7 joints affected. So that might be 2 hips and a knee. It might be 2 knees and a hip, for example. And they say, if I get this replaced now, I'll get more active and I'll be able to lose weight and my prognosis for those other joints will change. In theory and in principle, that's good. The unfortunate thing is when we've done longitudinal studies of people and followed them following joint replacement to see if activity and weight changes, it doesn't. So despite our best intents, it doesn't necessarily lead to favorable change in behavior. So what should we be doing as a community? Well, obviously, ideally, we should offer joint replacements to people who need it for the right person at the right time. But this is a randomized controlled trial from colleagues in Denmark, where they randomize people either to a total knee replacement or to a lifestyle and behavioral modification exercise program. And at 1 year, 74% of people who were in this non-surgical treatment group said, look, I'm quite happy with how I'm going. I know you said I was suitable for a knee replacement, but I don't actually think I need it. At 2 years, it's still a little over 2/3 of people are quite happy with that lifestyle and behavioral management. So if you're offered the opportunity, please do take it up, because the vast majority of people who do take it up do quite well longer term. Now, I guess just a little bit upon where we're headed and the things that might change over time. So we're very involved in doing research into an area called disease-modifying osteoarthritis drugs. So these are drugs that ultimately may consist of an injection into the knee that you might get every 6 to 12 months in an effort to help repair and regenerate the joint tissues. And so we say disease primarily because it's not only affecting the structure, but it's also hopefully affecting the symptoms related to osteoarthritis. I'm really pleased to say that there are a number of these trials that are in phase 3 therapeutic development. So this is the final stage of therapeutic development before we seek regulatory approval for the drugs. And they're showing promise in those earlier phase trials. And there's a hell of a lot of trials that are shortly following those. So these hopefully will be changing the way osteoarthritis is managed in the not too distant future and making a big difference, not only to structure, but also to the symptoms that you experience. So in closing, hopefully we've learned a little bit about some of the myths and misconceptions that are abounding with regards to osteoarthritis, and recognize that this is an extraordinarily prevalent problem and a leading cause of disability in our community. We're seeing more and more of it, not only because our community is getting older, but because of increasing numbers of people getting joint injuries and increasing numbers of people who are above a healthy weight. We need to change the way we conceptualize the disease, think about new ways of managing this disease so that it's not just thought of as the only way we can fix this is through surgery. I'd like to thank my both national and international collaborators, thank the people who fund the research that I do, thank the team that I work with in the clinic, and in particular, my research team, who I have the privilege and opportunity to work with on a regular basis. I'm going to skip through that and open it up for questions. And Andrew, do you want me to close the slides off? Or...
No, you can leave that there. That's great. It's question time. And look, I firstly would like to thank you before we get into questions. It became quite evident to me why you're one of the leading experts in osteoarthritis in the world. And I hope that the audience certainly received this information and understands that it's very evidence-based and very thorough. And if I was to try to summarize some of the questions that came through thematically, Professor Hunter, you really did touch upon them and follow up with some of the real inquiries. But I think even just based on the content, based on the journey we've taken tonight, I suppose one of the key questions to sort of summarize is, how best can the consumers play an active role around discussions about joint replacement, around holistic assessment? These are things, observations I would make of your content going, well, it's about the therapeutic dynamic with the professional, and there's only so much a consumer can do, but what role might they play in raising those questions, asking those dialogues, or playing an active role in their management?
Yeah, so it's a great way to start, because to be honest, the key principle here is knowledge is power. You're all here tonight and hopefully learning a little bit about the disease, but the more you know about the disease, the more you understand about the disease, the more you know that you can do a lot to help your disease, the better you will be. And so generally what I suggest is get well informed, get educated. And so we've built a number of different resources in an effort to try to do that. So whether that be the My Joint Pain website, which we've built with Arthritis Australia, and we're in the process of updating that, and we'll relaunch in the middle of 2024. But in addition, obviously, since the advent of COVID and the increased numbers of people listening to podcasts, we've also started a joint action podcast. And so, if you've got a question there and it relates to, am I right to have surgery? Should I be having an injection? What supplement is right for me? What type of exercise should I be doing? Should I run? Should I walk? So lots of common types of questions. So we've tried to tackle those with experts around the world in the podcast in an effort to better inform consumers. But the more information you have, the better informed you are when you go along and seek clinical advice, the better you'll be able to tackle some of the advice that may be inappropriate when you're given it, and also ask the appropriate questions so that you're fully aware and informed, not only about the potential benefits, but the side effects, the costs, the likely duration of recovery. So those really important questions, it's really important you be forearmed and forewarned, because expectation here is really important as well. And so if you know about the likely benefits, the likely harms, your expectations will be more realistic and your outcomes likely similarly. So the fact that you're here is a really good sign, but the more informed and educated you are, by far and away, the better. And that's a really key tenet and principle for us managing this disease.
Brilliant. Just Leslie, I'm not sure if you are Leslie, but you've got your hand up. If you just unmute yourself just before you ask Professor Hunter your question. It's an organic question coming directly from you now.
Yep. First of all, Andrew, thank you very much for organising, and David, that was fantastic. Thank you so much for definitely dispelling some myths. I got a few questions all rolled into one, if I can indulge. But I just noticed someone on the chat saying, should we all be on turmeric? I tried turmeric for a couple of months, didn't work. I've tried rosehip, which was the latest, great thing on the internet. I've been on it for 4 or 5 weeks, enough time for it to work. Hasn't really worked. I've had the classic diagnosis. As you say, I didn't think it was a disease. My classic diagnosis, I've been playing sport all my life. Worn cartilage from a lot of sport. Meniscus tears in both knees. My belief, probably will get worse. And people have been saying to me, oh, give it a rest, stop playing tennis. And I've sort of refused. But what's your thoughts about, I've just been to the osteopath this afternoon again, and that seems to be helping. Acupuncture helps, at least in the short term. But what's your thoughts about, well, I've just been very active all my life. I've played a lot of sports and I've worn out my cartilage. That's kind of the diagnosis that I received.
Yeah. So there's a lot of points that you're making, Leslie. So let me touch upon many of them. So let me start with that concept about that runs around in the community, that your joints only have so many steps in them, and that they're like tires in a car, and that the more activity that you do, you're going to actually wear them out. Well, again, that's an important myth and misconception that's not true. So that if we do appropriate activity, it's actually good for our joint. Most of the joint tissues are what we call trophic, meaning that they respond favorably and well to dynamic input from physical activity. So the more activity generally you do for your joints and your joint health, the better. if we do, and this has happened before, but if we do studies of people like astronauts, people who unfortunately have spinal injuries and end up in a wheelchair, the lack of activity, the lack of input that comes from physical activity leads to loss of joint tissue. So general message here is your joints, as long as you're doing safe, sensible activity, they benefit from that activity. So don't listen to that adage that your joints only have a limited number of steps in them. So, what should you do? Well, I would in general encourage you to go along and visit a very proactive, empowering health professional, whether that be a physiotherapist or someone of that nature, to provide you with the right advice about how to stay active, how to do so safely with strong, hopefully functional joints, and with an ideal body weight, because they're the key principles and central tenets about the disease. Now, the first thing that you started off with, you started talking about supplements, and I'll just, I guess, make a few words about supplements because, there's a lot of community interest. In fact, about 70% of people with osteoarthritis are on some form of supplement, and most studies would suggest people out there in the community are spending about $1,500 a year on supplements. So we've done a little bit of work in this space and published reasonably extensively on the use of supplements, and did a systematic review with one of my PhD students, which was now published a few years ago, but remains relatively current. And essentially what it found, and we analyzed all of the supplements that are out there that are used for osteoarthritis, we found that the ones that are used most commonly, specifically glucosamine and chondroitin, don't have a clinically meaningful effect over and above a sugar tablet, essentially a placebo. There are a number of others, and here I'll put on that list things like curcumin, as long as it's packaged with piperine so you actually absorb it. Pycnogenol, which is a marine pine bark extract. MSM and boswellia, that did appear to have clinically meaningful effects, but unfortunately, the trial quality, so the quality of the trials that were done in, wasn't rigorous enough for us to walk away from and say, well, that's something we should recommend for everybody who has osteoarthritis. So at this point in time, there are no guidelines that will advocate for the use of those products, primarily because the trial quality was so poor. So we're actively researching those supplements that I just mentioned to see whether we can create more rigorous evidence. Hopefully that addresses some of those points that you mentioned.
And I just got a couple of hands up, and just in terms of time management, I just want to put out that I've popped an email address in the chat, and I'll just double check with Professor Hunter if he's comfortable with any follow-up questions directly to his email presented on the slides, just in case we run out of time and there are individual questions that may not be able to be addressed today. I'm trying to summarize for the sake of time management.
Yeah, what I would probably prefer people to do, if that's okay, Andrew, is rely upon the podcast, rely upon the My Joint Pain, reach out to you.
Yep.
But if you've done that and you've informed yourself and you've educated yourself and it hasn't addressed the question you have, by all means, reach out to me. But understand that it may take a little while to get back to me. I get about 250 emails a day and I don't get to all of them.
Yeah, so in fact, I'll amend my statement and suggest that, definitely bring your questions through me. And as I said, the podcast is on the slide now. So if you are a user of your smartphones, you can certainly seek that out. And as Professor Hunter said, he has and have intentionally done a deliberately deep range of subject matters that you can find a short and entertaining podcast on the content of your interest. The one question, Professor Hunter, just because there was a tantalizing carrot dangled in front of these guys, and it just may be helpful to give them a sense of the phase 3 studies and what near future might look like. If that, I know there will be lots of variables involved in that kind of timeline, but what does near future perhaps mean for some of those frontier therapies that are on the horizon?
Yeah, so let me touch upon, I guess, both of those that are in phase 3 to give a sense of the timeline here. So this is an injection of a cellular-based product that releases a growth factor, and at least in phase 2 trials appeared to meaningfully help with both pain, but also the regeneration of joint tissue. They're closing their follow-up of their phase 3 trial in the middle of 2024. And so we will know by late 2024 whether this was effective or not. Usually the time course of events is when you finish your phase 3, it's probably going to take you about 6 to 8 months to get to the regulatory filing. And then after that, it becomes commercially available, at least in the US. How long it takes to get to Australia is, a variable length of string that can vary dramatically. But just to give you a sense, this is an injection you'd have every 6 to 9 months, potentially for the duration of the disease. Similarly for the Samumed liracetivir product, similar effects, an injection every 6 months that helps to regenerate joint tissue and pain. And it's a similar time course in terms of where that's at with regards regulatory filing.
Yeah, and who knows what would happen there. Look, just in the interest of time, we've got 2 other questions I'll leave. Give us 5 minutes to sort of wrap up. They relate to whether or not there is any value in seeing a rheumatologist if you have OA, and what the situation might be where that might escalate up to rheumatology kind of oversight. And the second would be to do with when joint replacement is what kind of conversations need to be had about suitability of joint replacement, if there's just some quick commentary on those 2.
Yeah. So the first question, I mean, I'm obviously a rheumatologist. For the vast majority of rheumatologists, their primary interest is in the management and treatment of bone, joint, and muscle diseases. So that's a medical physician specialty. They largely, in general, from a specialty perspective, focus on inflammatory rheumatic diseases like rheumatoid arthritis, lupus, scleroderma. There is a small number of us, and when I say a small number in Australia, there's probably about 10 to 20 who have a predominant interest in osteoarthritis. And so in general, I would advocate that in the first instance, the people that you should see to help manage your disease should be likely your general practitioner, ideally also more often than not a physiotherapist or an exercise physiologist to help you with therapeutic muscle strengthening, increasing physical activity. And if you're above a healthy weight, to see a dietitian. And those 3 health professionals, I think, are probably core to the management of osteoarthritis. If the disease is complicated, if the diagnosis is unclear or uncertain, if you're struggling with those core treatments that I mentioned a moment ago, so physical activity, exercise, and weight management, then by all means see a rheumatologist, but I wouldn't do it as the first port of call. I'm very fortunate that I work in what we call a multidisciplinary context. So I work alongside physiotherapists, dietitians, occupational therapists, psychologists in clinics that help to manage people that have osteoarthritis from the different aspects that they present to us with. And my role there is fortunately limited because I work with such a skilled and talented team. So I'm quite spoilt in that regard. The second question, Andrew, that you asked was about the timing and suitability for joint replacement. So I spoke a little bit tonight about those people who are more likely to have a poor response. In general, joint replacement is considered for people who have end-stage disease, where they have pain and unremitting functional limitation despite optimal other treatments, okay? So what we've found in general is that if you fit that category, the vast majority of people who go on and get a joint replacement have a great outcome related to their joint replacement. But about 80% of people who present for a joint replacement haven't had any appropriate lifestyle behavioral treatment before they get to the surgeon to have that joint replacement considered. So please, I'm here really to stress the importance of that lifestyle behavioral management, because we know it makes a big difference. The vast majority of people who pursue that will do well longer term. So try to arm yourselves with those tools to better enable yourself to get out there and do that.
Yeah, brilliant. And look, I think in the interest of time and such a thorough presentation, I appreciate that realistically the audience would keep you here all night, Professor Hunter, if they could. There will be a series of questions, and I'm sure we've all got places to be. I thank you so much for your time and for your expertise and for the evidence you presented. I know from viewing the chat and kind of the engagement with the audience, this has been highly valuable and really appreciated. I thank everyone for attending tonight. I really hope it's also been to your benefit. You've learned a lot and maybe had some of those ideas that you've long held challenged in good and positive ways, and there's been some actionable outcomes from tonight with respects to what you might take away from this and the next steps you might look to pursue. And Arthritis New South Wales thanks you for your continued patronage and participation in our webinar series for 2023. And we look forward to seeing many of you next year in 2024. Once again, Professor Hunter, thank you so much for your time. Really appreciate it.
It's my absolute pleasure, Andrew, and huge accolades to Arthritis New South Wales for the wonderful work that they do in reaching out to the community and making a difference. So if you've got an opportunity to help support Arthritis New South Wales, please go ahead and do so. And thank you so much for being here tonight and the opportunity to spend a little bit of time with you. It's a privilege.
Thanks so much, guys. Thank you very much, everybody.
Thank you, Professor.